Melanie, please confirm once we're live. Thank you.
My apologies, we are live.
Thank you. Janine, we normally wait a few minutes to allow participants to come in or attendees to come in. So far we're on 0. So normally Prof suggests that we wait, give it a minute or two, and then you're welcome to take over. Thank you.
Day 3 of Good morning and welcome to day 3 of our SCDG Research Week. This is session 1 where we'll be focusing on SCDG Goal 3, Good Health and Wellbeing. And the topic here is particularly around health and understanding the burden of disease. Thank you for all of you who are in attendance. Please do make use of the Q&A if you have any questions as we're going through, and we will pause for a Q&A session with the panelists, one in the middle and one then towards the end of the session before lunchtime. So if I can have the first speaker's bio, please. Our first speaker is Ms. Moketi. She achieved a Bachelor's of Nursing degree from Nelson Mandela University, a milestone that marked the beginning of her nursing career. But she didn't stop there. She continued to expand her knowledge and skills. In 2018, she earned a postgraduate diploma in HIV/AIDS management from Stellenbosch University, further deepening her expertise in the field. In 2020, she added a nursing administration and education qualification from the University of South Africa to her academic accomplishments. Her thirst for knowledge led her to pursue a master's in public health from the University of the Western Cape in, I'm assuming, 2023, not 2003, majoring in monitoring and evaluation and policy analysis. Currently, she's in the initial processes of a master's in project management at the prestigious University of Cape Town. Ms. Moketi, over to you.
Thank you, Janine. I'll just share my screen. I'm not sure if everyone can see my screen.
Yes, it shows. Thank you.
All right. Okay, thank you for such a good introduction, Janine. And I would like to greet everyone in the panel and all the spectators who are here today. So my topic that I'll be discussing, of which I'm at the end of my thesis submission, is exploring barriers to TB contact tracing and screening in perspective of healthcare providers in Eastern Cape Province, South Africa. So as we all know, TB still remains the major public health challenge due to many factors, especially in low-income countries where there's still poverty and there's people living in overcrowding, which is so hard to control TB in such living conditions. South Africa experiences one of the highest TB incident rates globally, and of course, as I've said, the major problem we're facing in South Africa currently is people living in overcrowding areas, and of course, minings are also contributing to the TB stat rates. So COVID-19 increased the TB crisis in 2021. The main reason for this was because majority of the health facility were closed. People were not tested for TB because everyone was more afraid of contacting COVID-19. So TB clients were missed. We missed the contacts. We missed the case index. There were no tracing done during the stage of COVID. In 2021, TB claimed 1.6 million lives globally. The other major issue with TB is the MDR, which is currently one TB that's increasing. Before we had PTB, pulmonary TB, which was the major issue, but now the most major issue we're currently facing is the MDR, which is our multiple drug resistant TB. To address this worsening situation, WHO has put forth a series of recommendations and strategies. This encompasses vital components such as enhanced screening and contact tracing, and identify and isolate the cases promptly. But we're still facing challenges of actually going to the contacts to find them and isolate them because of such areas that are not safe for everyone, for most people, actually for traces. So the aim of the study is to explore and describe the barriers that influence TB contact tracing and screening in Epai Township, Eastern Cape Province, South Africa. The objective of the study is to explore and describe barriers to TB contact tracing, to explore and describe barriers to TB screening, then to propose the recommendation to inform policy and practice on how to improve TB contact tracing and screening. The methodology for this study was qualitative, descriptive, exploratory design was adopted because we wanted to get the in-depth information with regards to the contact tracing, the TB contact tracing and screening. So we wanted like deep information from the people who are actually familiar with TB contact tracing, and we were looking at people that are very experienced in the field that has been there before the COVID, during the COVID, and after the COVID. So the interview were conducted with 12 participants, which were made up of nurses and community healthcare workers, because they are the people who currently working with TB contact tracing and testing. They are actually the ones who go to the houses of the people and do the whole contact tracing and screening. So the theoretical framework that was useful to describe the level of influence affecting TB is social ecological model, which is also known as SAM. Also, basically, this is the SAM model, which actually states how individual level is affected in interpersonal level, organizational level, community level, and health system level. So I'll be describing the barriers to TB tracing based on those 5 levels. Okay, the first one, the individual level, the participants complained of lack of training. Most participants stated that, especially after COVID-19, majority of people who are brought in to come and do the contact tracing and screening were not trained, which puts a strain on other workers that have been there for years, which contributed to the burnout, which is my next point. So majority of those people who've been there for years are currently facing burnout because they feel like the people that are currently there are undertrained. And also cultural and language barrier. There's so much cultural and language barrier in individual level with nurses and the clients, where the nurses feel like they can't communicate with the clients because, as we know, we've got a lot of people, we've got different languages in South Africa, and people are migrating everywhere where they want to be. So that's the major issue. Even with cultural, some places we still face where the woman can't even go to the clinic without informing the man. So those are some of the issues that they currently face. And at the interpersonal level, it's discrimination and stigmatization amongst the healthcare workers. So usually when the healthcare workers that are working in TB areas, they are faced with such stigmatization and discrimination, they believe that since those people are more exposed to TB, they're at high risk of having TB, so the people will want to isolate themselves from those nurses or healthcare workers. And the other problem is the conflicts among the healthcare workers, which causes a lot of problems when it comes to TB tracing and screening and patient engagements. Some participants complained about how other staff members, especially the nurses, will talk to the clients when they come to the facility to seek help, whether it's contact tracing or it's clients that is coming in for their medication. Organizational level will be the workload. A lot of staff members complain about the workload. They say the workload is too much when it comes to TB. There's a lot of paperwork. There's a lot of walking, especially when it comes to tracing, because majority of facilities don't have their own transport, which I'll discuss more in the lack of resources. And the facility policies, majority of the facilities that I went to didn't have the actual policy that describe how the actual contact tracing and testing should be done by the healthcare workers. So they've got a little support when it comes to such policies. The community.
You've got 5 minutes left.
So, okay. Community level, it's the lack of community awareness and resistance. They usually face resistance among the community members, where sometimes the community wouldn't even want to see the healthcare workers in the community because they feel like they being attacked, or they will be exposed that they've got TB or they're associated with HIV. Also, crime in the community. They complain about the crime in the community. There's a lot of crime when they go into the communities because they walk, they get robbed, and they feel like they're not safe in some areas. In health system level, the overcrowding in healthcare, the lack of resources. As I said, I'll go back to the transport issue. The transport issue is the major issue they're currently facing. When it's raining, they can't do any contact tracing because they must walk, because they share one car among a lot of facilities. So if they can't get a car, they can't go for contact tracing or look for missed clients. And the health system strain was also another finding that was found during the research. So in conclusion, I would like to say TB still remain a complex issue influenced by various factors at different levels. Understanding these factors is very crucial for effective intervention. Our study sheds light on challenges faced by healthcare providers in Epai, which is not only in Epai, actually all over South Africa. Of course, we'll face different issues since we from different areas. The urban area might face different issues compared to the rural areas. And it's essential to continue working towards improving TB control rather than focusing on the curative care of the TB. Thank you so much.
Thank you, Ms. Moketi. Thank you for sharing your findings there. I think it's really important for us to look at some of the challenges that are related to this very real issue in South Africa. So thank you so much for sharing your research findings. May I have the next presenter's bio, please? Our next presenter is Dr. Rumini, who has a diverse educational background with a strong focus on public health. She holds a PhD in public health, a master's in public health degree with a specialization in epidemiology and biostatistics, and a bachelor's degree in disaster risk management, honors, and microbiology. Currently, she serves as a senior scientist at the South African Medical Research Council. In this role, she is responsible for reporting the findings of the 3rd South African Interim Mortality Survey. Additionally, she contributed to the South African Comparative Risk Assessment 2 project, where she led research on ambient air and household air pollution, and contributed to the development of the online risk assessment tool. Dr. Rumini, over to you.
Thank you. Let me just share my presentation. Okay, I assume everyone can see.
Yes, can you just put it in slideshow mode, please? There we go, perfect.
Okay. Okay, my name is Rivka. Thank you for the introduction. I'll be presenting on my research from my thesis, my PhD thesis, 1 in 5 South Africans are multimorbid. And my supervisor was Brian van Wyk, Prof. Brian van Wyk, and Victoria Pillay van Wyk, and my colleague Annabelle Kois. So just to give a, just to give an outline of my presentation, I'm going to go through a couple of definitions, introduction, the objectives, methods, results, and discussion. So a good starting point is, what is multimorbidity? There's a lot of different definitions for this, but one that's agreed upon is when someone has 2 or more long-term health conditions, but it can be defined in various ways. Okay, so multimorbidity is a major public health concern, and this is due to populations aging and as non-communicable diseases are rising. And you can see in this graph, I'm not sure if you can actually see my mouse pointing, but in the graph on the in the figure on the right, you can see South Africa shows that the population is aging as well. People with multimorbidity tend to have poorer health outcomes, higher mortality rates, and increased levels of healthcare utilization, as well as increased levels of polypharmacy. So although multimorbidity is considered a global research priority, little is known about it in low and middle income countries such as South Africa. We have the largest burden of HIV worldwide, but also a growing burden of NCDs, and this could lead to combinations that we don't see in other countries, disease combinations. Information about the prevalence of multimorbidity, the factors associated, and the type of diseases that we see clustering can be used to assist in healthcare planning and the targeting groups of people for interventions. So if we look at in terms of the Sustainable Development Goals, I thought that it obviously goes under goal 3, which is to ensure healthy lives and promote well-being for all at all ages. Sorry. And then if you look at the target specifically, while there's nothing that speaks to multimorbidity specifically, but there are targets around fighting communicable disease, reducing mortality from non-communicable disease, and promoting mental health, and achieving universal health coverage would obviously be important to people with multimorbidity. So the objectives of this presentation is to determine the prevalence of multimorbidity in males and females in South Africa, identify factors associated with multimorbidity, and then we're going to go through some of the common disease classes or clusters that we found. So we use the nationally representative South African Demographic and Health Survey, 2016 survey. It included about 10,000 people who participated in the adult health questionnaire. We define multimorbidity as having more than one disease, and this was quite a process to decide which of the diseases to include. We consulted with experts. We looked at systematic reviews for what other people have, what other researchers have done. So we included a mixture of self-reported disease and of biomarkers. So for example, in the self-reported disease, if we use the example of stroke, we can see that the respondent answered as a doctor, nurse, or health worker told you that you have had any of the following conditions, such as stroke. In terms of biomarkers, we were looking at diabetes, HIV, anemia, and high blood pressure. So the first part, the first thing to do was to estimate multimorbidity in the population. We created an index variable that counts the number of disease conditions present. And then we also looked at factors associated with multimorbidity using a logistic regression. And again, we looked at what information we have available, but we also looked at what was commonly associated with multimorbidity in other literature. To identify the disease clusters, we did a latent class analysis. I'm just going to read this bit of information quickly. So LCA, latent class analysis, is a cross-sectional latent variable mixture modeling technique, and it aims to find heterogeneity within the population. It probabilistically assigns each individual to a class. So the first step of it is to identify a suitable number of disease clusters or classes. And we run models with different numbers of clusters. We use something called fit statistics to decide which is the best fitting, which number of groups is the best fitting number. So I'm just going to take you through some of the results. This is a description of the sample population. Our median age was 36 years. 55% of people were in urban location. Most people had completed their secondary education. And seeing the chat. Okay, for me. Okay, and then we can look at the prevalence of the single disease conditions by sex and method of assessment. You can see there were high levels of HIV, hypertension, and anemia, which also happen to be the biomarkers. The number of diseases in individuals by sex. So 48.6% of the population had no disease. And when we say no disease, we're talking about no included diseases that we were looking at. They could have some other disease. And you can see it was quite, for males, it was 55.8%. 30.8% had one disease of the population, and then people that were multimorbid were 20.7%. And you can see that for females, it was 26.2% compared to males, which was 14.8%. If we break it down by age group, so we've got the prevalence on the going up and the age group at the bottom, we can see that as age increases, the prevalence of multimorbidity is increasing, and we can also see that it's higher in females than males. Okay, then we looked at the factors associated, so I'm just going to go through this very quickly. So we've already showed that age is associated with the increasing prevalence of multimorbidity, and that sex is also that it tends to be higher in females, and particularly for this is higher in young females compared to young males. So tertiary education was associated with a lower odds of having multimorbidity, and being employed was also associated with a lower odds of having multimorbidity. We also looked at alcohol use, which surprisingly came up as something that was associated with a lower odds of multimorbidity. But before you go this weekend out drinking and say that I told you to do it to lower your risk of multimorbidity, you have to keep the sick quitter effect into account. So that is that people that are sickly tend not to drink. So it might be that it messes with their medication. So it's not necessarily that because they are drinking, they are healthier. Okay, so now we're going to just look at the multimorbid population. So within the multimorbid population, you can see hypertension, anemia, HIV was very high. So this is the fit statistics of the latent class analysis, and all that's important here is that we chose 4 classes using these fit statistics. So there were 4 clusters of diseases. These 4 clusters were HIV related, anemia related, cardiovascular related, and diabetes and hypertension. I'm just quickly going to show that these were the probabilities for each latent class. So in the HIV-related group that we identify, 100% had HIV, and then 60% had hypertension, and just under 60% had anemia. And you can look at all the groups in this way. You can see anemia was high. Okay, I can't see because my video thing is blocking that. Hypertension and anemia were high. For the cardiovascular related group, we've got very high, 90% have hypertension. And we've got people with heart disease of almost 40% and 50% of high cholesterol. And hypertension and diabetes related, you can see that of those people, everyone had hypertension and diabetes.
Ms. Brimini,
So
you have 5 minutes left.
okay, thank you. Taking us into the discussion, so we found that 1 in 5 South Africans over the age of 15 years had more than one disease. The prevalence of multimorbidity increased with age and peaked in the 60 years and older age group. And this is something that we see internationally as well as in South African literature. We identified 4 latent classes in the population. So these were the disease clusters. Our HIV-related class was the largest disease cluster, and almost 40% of multimorbid people belong to this class. In terms of limitation, of course, we were limited to the survey data, and the self-report data might have been underreported. In conclusion, while South Africa has policies for major NCD risk factors, the implementation of these remain a challenge. Reducing these risk factors along with risk factors for HIV would presumably aid in reducing the prevalence of multimorbidity. And then I just wanted to leave with a question of, so if such a large proportion of the population are multimorbid, what does this actually mean for treatment and how we are treating people in the health facilities? Our papers were published and I got 2 minutes of fame on the news on ENCA. So that's all, thank you. And then just to acknowledge the DHS program, SAMRC and Burden of Disease Unit, and you can find me there. Thank you.
Thank you so much, Dr. Rimini. I think that's a really interesting insight into multimorbidity, which I think is, as you've shown, actually quite common, and very interesting implications in terms of that question you raised at the end about how do we treat these diseases when there is multimorbidity. You can't just treat one of them. And then you get into issues like looking at interactions between medications for treating the different morbidities. So yeah, very interesting research. I think raises some interesting questions for future research as well. May I please have the next speaker's bio? Our next speaker is Mr. Gert Rutte-van-Loo, who is originally from Cape Town, South Africa. His academic journey in biotechnology began at UWC. After completing his bachelor's degree, he pursued an honors program delving deeper into biotechnology. Now in the final year of his master's in biotechnology at UWC, he is passionate about using biotech to address global challenges. He believes in its potential to create a better and more inclusive future. Over to you.
Hi, let me just share my screen. Okay, nice to meet everyone. Good morning. So I'm in the yeast lab under Prof. Rian Denaan in the biotechnology department of UWC. So my project is based on the engineering of antimicrobial strains of Saccharomyces cerevisiae for non-sterile bioprocesses. And the aim was to genetically modify yeast strains to produce antimicrobial peptides for non-sterile fermentation. So our lab mainly focuses on the improving of yeast to improve biofuels productions. In order to produce biofuels, you convert biomass break it down into sugars, which is then used by yeast and converted into alcohol, which can be used as a biofuel. However, on an industrial scale, the microbial contamination is always there, almost always there. It's very difficult to keep it sterile, which results in a lower alcohol yield due to the microbes taking up available space, available nutrients, and so forth. The main contaminants found are lactic acid bacteria. And if you remove the lactic acid bacteria, opportunistic organisms might grow, taking up the still available nutrients. During fermentations, they tend to add antibiotics. That's one of the methods to reduce microbial contamination. However, this results in antimicrobial resistance increase, and it's one of the main causes of antimicrobial antibiotic resistance. And with the increase of antibiotic resistance and the reduced newer antibiotics available, we need an alternative to antibiotics. This is where antimicrobial peptides come in. So these are similar to antibiotics, except they are biological molecules encoded by a gene. They form part of the innate defense mechanism of most organisms. They have a high efficiency even at low concentration, and they have lower possibility of developing resistance compared to antibiotics. They can also be synthesized chemically, however, it's very expensive. Thus, it's a better option to synthesize them by expression in a microbial strain such as yeast. They have a lot of potential in the healthcare. As I said, they can be an alternative to antibiotic treatment. They even have anti-cancer properties. They can be used as a food preservative agent. They can be used to protect agriculture, and since they are peptides, they're encoded by a gene, and if we are able to genetically modify the gene, we might give it alternative properties. And with the rise in AI prediction, we might be able to use that to our advantage. So bacteriocins are AMPs that specifically target bacteria. And since we want to eliminate lactic acid bacteria, we're looking at specifically classification on the gram-positive side. We decided to look at the non-antibiotic or class 2A, since they are a very robust antimicrobial peptide or bacteriocin. They survive at high temperatures. They are only encoded by a single gene, so you don't need multiple genes for activity. And they are a very small gene, which is advantageous. And they do not require many post-translational modifications in order for the peptide to be active, which is the case in the others. Here's just a general structure of the class 2A bacteriocin. You can see here that the AMP embeds itself into the membrane, where it disrupts the membrane, causes pore formation, and essentially cell lysis. It can also integrate inside of the microbial cell, where it inhibits protein synthesis or DNA synthesis, or by another method of cell death eventually. So the main aim is to essentially take this AMP gene, insert it into our yeast strain to allow it to express the bacteriocin or AMP into the environment. You can do this either on episomal plasmid form or integrate it into the genome for permanent change. This allows yeast to grow in a non-sterile environment without the requirement of adding antibiotics or any other sterile treatment, which essentially will increase ethanol yield. So these were our objectives. Firstly, we identified and selected about 7 AMPs from online databases and peer-reviewed literature. We'd encode and optimize it for improved yeast expression. We cloned this gene into a lab strain, Saccharomyces cerevisiae yeast, for initial testing, antimicrobial testing against a panel of test organisms. And those that did show to be active, we then cloned into the genome for permanent of an industrial robust yeast strain. This is where we are currently. We then also want to do minimum inhibitory concentration assays to quantify the antimicrobial activity. We'd also want to insert multiple combinations of AMPs to see whether two or more have synergy, tested synergy. We also like to do lab scale evaluation fermentations to see where we culture both the recombinant yeast combined with the contaminant, microbial contaminant, to see whether it is inhibited or if it was effective during fermentation. So these are the 7 AMPs that we selected, except for Pediosyn PA1. We use that as a positive control since it's previously been shown to be expressed actively in Saccharomyces cerevisiae, specifically against Listeria strains, which we used as an indicator organism before testing other organisms such as lactic acid bacteria. We used AlphaFold to predict the structure of our AMPs. And you can see that most of them have the general beta sheet combined with the alpha helix, which is required for the mode of action where it embeds into the cell membrane. We did 2 antimicrobial testings. The first one was a soft agar overlay, in which case we spot plated our recombinant strain on agar media, and then we grew it for 3 days and overlaid it with a soft agar contaminated with a specific organism. In this case, it's Listeria initially as our initial indicator strain. And you can see that a zone of inhibition indicates antimicrobial activity, with Pediosyn here used as a positive. We also did a well diffusion method, in which case we used the cell-free supernatant and inoculated into wells of agar that were previously contaminated with the target organism. And again, you see zone of inhibition indicates antimicrobial activity. This is to test whether the AMP is secreted or found in the environment. And you can see here, this is about more or less what we found for our strains, in that these 3 did show activity when spot plated. However, once the supernatant was tested, there were no activity, which indicates that the AMP is either not secreted properly or it might be degraded in the supernatant. However, Pediosyn is not degraded, and most of our AMPs are similar to Pediosyn structure, so we suspect that it is either inactive in the cell-free supernatant or it's stuck somewhere inside of the yeast, maybe the cell wall. So to test this, we did Trishan STS page with the cell-free supernatant, and essentially here you can see on the left side there's a clear band indicating that the Pediosyn is present in supernatant. However, there's no bands in any of our strains, recombinant strains. And number B, you can see similarly, so we didn't duplicate. With the duplicate, we overlaid it with Listeria inoculated media, and you can see that there's a zone of inhibition by the Pediosyn, number 9, indicating that it is the Pediosyn that caused the antimicrobial activity and not some other thing in the environment. So essentially, this means that our AMP is not found in the cell-free supernatant. It's just a confirmation of it. So we focused on the spot plate agar overlay. This is the result we found with the lab strain. And you can see that many are, when we tested against Listeria,
4 minutes left.
And if Enterococcus faecalis, there were activity. However, not for all of our AMPs. We also tested against lactic acid bacteria and other strains. However, no activity, antimicrobial activity was found. So we moved on to genome integration, and we used the CRISPR-Cas9 system targeting delta sites, which is just multiple sites in the genome for a high integration copy number. We were able to integrate into the genome, but we weren't able to find any activity. So we tried using a different strain, 2 different strains, same results. We tried targeting a different sites. The chromosome 11 region, again, no activity was found. So we tried using a different integration method. We went back to the plasmid-based traditional method and even used 2 different promoters to see whether different expression levels might show different results. Again, no activity. And in the ethanol red industrial strain. So we went back to the lab strain to try to integrate into the genome of the lab strain. However, again, we were not able to find any activity. So in conclusion, we were able to integrate antimicrobial peptides into Saccharomyces cerevisiae lab strain on a plasmid based, and we were able to find activity against Listeria species as well as Enterococcus faecalis species. We are unable to integrate it or find activity of genome integrated AMPs. So although we weren't able to find activity against lactic acid bacteria, there are a great variety of other AMPs to be tested for future prospect, which might show activity. This research just shows that we are able to do this. We just need the right AMP. And since yeast are eukaryotic, this research might give insights into potential applications or in higher organisms, or maybe have medical applications as well. Thank you so much for your time. If you have any questions, you're welcome to ask.
Thanks so much, Mr. Pandal. Thank you for sharing your findings. And I think what this highlights for me is that sometimes we don't get the answers we think we're going to get from research, and oftentimes we end up with more questions at the end and more potential for future research in the end. So thank you so much. Please do make use of the Q&A section for typing your questions in the meantime, but we will address those questions in a live Q&A shortly. I think we've just got 2 more presenters before we have that live Q&A. May I have the next bio slide? Our next presenter is Ms. Fasadine, who is a second-year master's student in research psychology and a research intern at the University of the Western Cape's Health Promotion and Wellness Unit.
Hello, can everyone hear me? I'm just trying to navigate my way here.
Yes, we can hear you.
Okay, great. Hi, good morning, everybody. So my name is Tahira, and I'm going to be presenting on the psychoeducation and behavior change, a call for critical approaches study. So just to give you a brief introduction, within South Africa, there are high violence, trauma and poverty rates that exacerbate mental health, physical health, and other health and wellness related concerns. Studies have indicated that common barriers include stigma as well as accessibility issues. So thus, with a limited healthcare resources, there is a need to explore alternative cost-effective psychosocial strategies, as well as explore more interventions that promote lasting change within a South African context. So speaking to the problem statement and the aim, we noted that in South Africa, in low-income communities, interventions aimed at addressing risky behaviors have historically emphasized knowledge dissemination as a means to introduce behavior change. However, the efficacy of knowledge dissemination approaches in this context has remained ambiguous. Therefore, the primary aim of the study was to discern prevalent trends in knowledge dissemination, as well as peer interventions targeting risky health behaviors within South African low-income communities. Additionally, the aim was to explore or address the need for effective interventions, particularly among South African youth and tertiary institutions, by evaluating what approaches work best for health prevention and promotion in South Africa. You'd see the study does place critical emphasis on the psychoeducational approach, as it is the predominant method identified for knowledge dissemination. In terms of the methodology, we made use of a narrative review to conduct the critical evaluation of the psychoeducational approach, as well as explore what forms of knowledge disseminations is currently prevalent within the South African context, as well as peer-led interventions. So just briefly speaking to trends in knowledge disseminations and peer-led intervention, we know that knowledge dissemination refers to a process of sharing information and spreading knowledge on a target audience. Some of the common trends we found in knowledge dissemination methods were peer-led initiatives in which peer educators are trained to drive knowledge and behavior change, as well as school and community efforts in which education is provided to all regardless of which setting, and a lot of participation methods as well as psychoeducation methods is involved. We noted that there are also specific trends with regards to peer-led interventions of knowledge dissemination related to the specific topic, such as in the case of sexual health and HIV and AIDS, the topics were HIV awareness and relationship practices, awareness of a risk and denial of vulnerability, awareness of rights and claim on rights, and HIV knowledge and HIV stigma. So if we move on to the next, with regards to the advantages of peer-led interventions, peer-led interventions have been recognized as an effective approach in knowledge dissemination, particularly in the field of youth mental health, sexual health, contraception, and HIV and AIDS interventions in South Africa. And some of the advantages include the peer-led education, in which trained peers use relatable language and personal experience to engage and educate their peers by increasing awareness on health and wellness related topics. They provide programs which improve knowledge and promote practices which reduce risky behavior in South African adolescents. The interventions also offer a secure and comfortable space for youth to discuss sensitive topics, leading to better forms of engagement as well as better health outcomes. And there is a predominant use of the psychoeducational approach, to which I will explain later in the presentation. So when exploring certain studies on the effectiveness of the peer-led intervention approach within South Africa, we did come across a few previous studies as well as recent studies noting the influences peer-led interventions have, or the advantages they have. And majority of these studies were related to interventions based on sexual health and contraception, as well as HIV and AIDS. So as you can see, for example, a peer-led behavioral intervention resulted in positive change in attitudes and behaviors related to reducing sexual practices of young adults. Another study noted the improvement of knowledge amongst prison inmates on information of HIV and AIDS, as well as sexually transmitted infection. So when we're moving on to the assumptions underpinning peer-led interventions, we know that the psychoeducational approach is commonly used approach in peer-led interventions within South Africa. So the psychoeducation model itself is a cost-effective interventional approach in which individuals are provided with information and education about mental health conditions, illnesses, disease, or specific challenges that they may encounter. This method includes teaching individuals about symptoms, causes, treatment options, and strategies for effective condition management. Psychoeducation is normally delivered through group sessions, education materials, or one-on-one counseling. The psychoeducational approach in peer-led programs is effective because it allows for peer-to-peer connection and support, and this approach empowers individuals by equipping them with knowledge and skills to manage their mental health effectively. Peers find this approach very helpful in that they feel like they can relate to each other through their experiences, as well as give them a safe and non-judgmental space for discussion. Essentially, when we are connecting all factors of the psychoeducational approach, the peer-led approaches, as well as the health promotion approach, we note that the psychoeducational approach is a method that combines education and psychological interventions to promote mental health and well-being, and aims to improve overall knowledge and skills to individuals to understand and manage their own health, well-being, and conditions or challenges. In the context of health promotion, the psychoeducational approach is used to raise awareness about specific issues like HIV, STI, TB, mental health, and much more health and wellness related issues. And it's used to empower individuals to make informed decisions and adopt healthier behaviors. With regards to the peer-led interventions, psychoeducation approach assists peer educators with the necessary knowledge, skills to deliver accurate and evidence-based information, as well as facilitate and support discussions aimed at behavior change. When we say it's rooted in health promotion, the primary goal of psychoeducation intervention is to persuade individuals to adopt health-promoting behaviors. Therefore, the health promotion model is regarded as a good conceptual framework for the psychoeducation model because it highlights contextual elements that influence health behavior, as well as helps with identification of intervention components. So when speaking to does the psychoeducation approach work, there were numerous studies that we found that speaks to the efficacy of the psychoeducation model. However, what we did note was that there was a lot of prominent studies done within African countries, but there is still a limitation of these sort of studies within South Africa. Some of the prominent interventions that speak to the psychoeducational approach being effective is the supermarket intervention. It aimed at strengthening family level economic abilities, as well as a study that was conducted in South Africa. It noted the Vuslilo curriculum-based behavioral intervention, which use psychoeducation and peer-based approaches to improve mental health, as well as increase satisfaction with social support. So these interventions highlight the importance of providing information and skills to adolescents and young and youth by empowering them to make informed decisions, as well as engage in positive behaviors. There are challenges that was identified, and these challenges consist of cultural relevance, socioeconomic factors, as well as power dynamics. So we know psychoeducation often relies on Western models, as well as mainstream psychological ideas that may not align with South African cultural values, thus limiting its effectiveness in addressing local mental health challenges. Psychoeconomic factors refer to the apartheid's legacy and the ongoing inequality that affect access to using psychoeducation within a South African context, as well as the socioeconomic barriers like poverty that hinder engagement and cause for structural reforms. In terms of the power dynamics, we know
4 minutes left.
No, thank you. In terms of the power dynamics, Western psychology perspectives and European scholars normally marginalize local voices. So this power imbalance influences psychoeducation and delivery. There's a prominent use of edutainment when engaging in participation factors of psychoeducation, although it is helpful in terms of providing interactive videos, enhancing engagement. There is certain challenges such as the lack of critical engagements, as well as the limited participation that occurs in the form of critical engagement. So thus we call for more critical approaches, and there's a shift towards attaining a critical consciousness, as well as providing traditional psychoeducation, mainly on knowledge transfer and skills building, to employ more critical thinking, as well to effect more lasting behavior change. Furthermore, in peer-led programs, there tend to be a focus on individual coping strategies and self-care techniques. So while this is important, they may not address the underlying structural factors that contribute to mental health and wellness disparities. Thus, the lack of critical consciousness aspect in psychoeducation may limit the intervention's ability to address root causes of the issues. To enhance the effectiveness of peer-led programs, it's crucial to incorporate critical consciousness. And an example would be to employ, for example, in lessons for HIV and AIDS programs, information should be geared towards giving individuals opportunities to develop consciousness of how socially constructed norms of masculinity and femininity jeopardize sexual health, as well as the belief of alternative gender relations. So in conclusion, while the presentation has focused on the assumptions underpinning peer-led interventions, there's still a need for rigorous longitudinal studies, including RCTs, examining the efficacy of psychoeducation approaches in South Africa, especially given the mixed findings pertaining to education as a strategy in public health intervention. As highlighted above, context-specific, localized, customized, youth-led interventions that facilitate strong participation seem to be more strongly supported. However, this seems to be out of step with what current approaches use, generic large-scale methods incorporating a Western framework. Thus, the assumption that knowledge dissemination is a passive activity is the assumption that requires the greatest engagement. The work of Paulo Freire on critical conscientization provides a useful framework for current approaches to psychoeducation. We need to develop approaches to behavior change that incorporate both the individual reflections and changes in their behavior, as well as the examination of the context that determines the risk and constraints healthy outcomes. So thus, we need to use these approaches not only to promote personal growth, but also to develop or use it as a vehicle to develop collective lasting change. Thank you. References.
Thank you so much for sharing those findings. I think it's very useful to look, like, as you say, a critical reflection on our psychoeducation practices and even educational practices in our context at UWC, making sure we're keeping contextual issues in mind and not just applying what's coming from other contexts as well. So thank you so much for sharing your findings there. If you have any questions, please add those to the Q&A and we will address those after this presentation. Our next speaker is Ms. Khamaldin, who is a UWC PhD medical bioscience candidate. She completed her undergraduate degree as well as her postgraduate degrees, honors and masters in medical bioscience. Her honors research focused on the use of lipogram measurements and carotid intima media thickness to detect the prevalence of early signs of cardiovascular disease in adolescents. Her master's research focuses on the association of BMI and blood pressure measurements with depressive scores in university students. Her current research focuses on the relationship between frailty and mental health symptoms with carotid artery measurements in a predominantly Black South African urban and rural population. She is also a teaching assistant in the department and hopes to make a positive impact on the lives of undergraduate students. Over to you, Ms. Khamaldin.
Thanks. Let me just share my screen. Oops, sorry. Can everyone see?
Yes, we can. Thank you.
Okay, perfect. Thanks. So good morning, everyone. My name's Amara, and today I'll be presenting my master's research. The title is The Association of Anthropometric Measurements, Blood Pressure Measurements, and Lipid Profiles with Mental Health Symptoms in University Students. So just a introduction. Depression is a very common and serious mental illness, and major depressive disorder can be characterized by having a constant low mood or loss of interest in activities which were once enjoyed. And this must be characterized over a period of 2 weeks. And in South Africa, 1 in 6 people suffer from substance abuse, anxiety, or depression. Then if you look at the diagram on the side, you can see the numerous effects of the brain on the brain depression has. So it results in neuroinflammation, which is the cellular and molecular changes in the brain, which leads to the loss of appetite, fever, and muscle pain, and numerous other things. Neurotransmitter imbalance, such as the imbalance of serotonin, norepinephrine, as well as dopamine, which results in depression, anxiety, and panic attacks, as well as insomnia. Then when moving on to synapse dysfunction, it results in the impairment of information processing, and this results in the destabilization and loss of synaptic connections in mood and emotion. Then lastly, the impairment of neurogenesis, which means there is a reduction in the formation of neurons within the brain, and this results in the reduced cognitive function, memory impairment, as well as the inability to control mood. Then mental health status of South African university students is a serious health concern, and this is because there's been an exponential increase in the number of suicides in university students across South Africa. And there is a shortage of comprehensive data on the prevalence of depression within South African universities. And research has shown that university students actually have a higher rate of depression compared to the general population. And even though there is a access to mental health care at campuses, students still struggle to access support for their mental well-being. Moving on to the aims and objectives. The aim was to determine the association of anthropometric measurements, blood pressure measurements, and lipid profiles with depressive scores in university students, which were UWC students. The objectives was to use standardized questionnaires to measure the severity of depression, to determine if these measurements associated with depression, and taking it further by obtaining food intake as well as sleep patterns to see if they associated with depressive scores. And then we also had secondary objectives, which was to determine the association between the variables and their relationship to cardiometabolic disease. So moving on to methods, it was a cross-sectional study. 63 participants were included. It was both male and female students. First year to PhD students were included, and they were 18 and older. They were excluded if they showed signs of suicide or if they had a history of substance abuse, and they were referred to either the campus doctor or a psychiatric facility at Tygerberg if they had these signs. Now, depressive scores, they were measured according to standardized questionnaires, such as the Montgomery-Åsberg Depression Rating Scale, known as MADRS, and the Beck Depression Inventory, which is known as BDI. The Montgomery was interviewed, while the BDI was self-report. So according to MADRS, there were 32 that were assigned to the control group, while 31 were assigned to the depressive group. And according to BDI, 30 were assigned to the control group, while 30 were assigned to the depressive group. When moving on to anthropometry, weight, height, waist circumference, and hip circumference were all measured according to the Center of Disease Control protocol, while the ratios such as body mass index, waist to hip ratio, and waist to height ratio, they were all calculated according to World Health Organization standards. Then blood pressure was measured using an Affimedix automated blood pressure machine, and lipid profiles were calculated using the CardioCheck analyzer via the finger prick method and using lipid panel strips. Now, this method was validated by the UK NHS Purchasing and Supply Agency. And then the lipids that were calculated were total cholesterol, low density lipoprotein cholesterol, high density lipoprotein cholesterol, triglycerides, as well as total cholesterol over HDL ratio. The ethics was obtained by the BMREC committee at the University of the Western Cape. Then when moving on to the results, when looking at figure 1, you can see that most participants were moderately depressed according to both BDI and MADRS depressive scores. And then secondly, they were mildly depressed. Then when looking at table 1, looking at the main results, we can see that there were no significant anthropometric measurements and no lipid profiles which were significantly correlated with either the BDI or MADRS depressive scores. However, there were significant blood pressure results, which was systolic blood pressure, which was significantly correlated with MADRS scores, but in males only. So because there were no significant results with anthropometry and lipids, we did further analysis, which was a point by serial correlation, and this gave us a total cholesterol and low density lipoprotein cholesterol, which were negatively associated with depression, being the MADRS scores, and triglycerides, which were positively associated with depression, where significance was less than 0.05 respectively. Then when looking at the extended variables, which was food intake and sleep, depression was not associated with the food intake, but there was a significant association with how long it takes participants to fall asleep. And then there were also many secondary findings, but I will just focus on the main findings today. So moving on to the discussion. The aim of the study was to determine the association of BMI, blood pressure, and lipid profiles with depressive scores in university students at UWC. Now, the prevalence among the population was quite high, which was 47.61 when comparing it to other studies of a similar population. Studies carried out by Berhanu, Melis, and Desi and colleagues all had a prevalence ranging from 21.6 to 32.2. Now, the difference in prevalence could have been because of sample size, different socioeconomic factors, such as age, level of education, as well as financial status. Then when moving on to anthropometric measurements, as I mentioned, there was no associations between the anthropometric measurements with the depressive scores, and the results concerning the association between BMI and depression are inconsistent, and this is in terms of research. So some studies have found a positive correlation, while some have found a negative association, and some have even found no association between BMI and depression. Now, interestingly, a study completed in the Netherlands wanted to investigate if there was a U-shaped association between BMI and depression. So this means that both underweight and overweight categories could associate with depression. And they found that BMI categories did significantly associate with depression. So for my study, I could have included a U-shape association because students with low BMIs had high depressive scores, but those with high BMIs didn't necessarily have high depressive scores. So I did not find a linear association. So when moving on to the lipid profiles and depression, I mentioned that total cholesterol and low density lipoprotein cholesterol, they negatively associated with MADRS scores, while triglycerides positively associated with depressive scores. So this means that lower total cholesterol and lower low density lipoprotein measurements will result in higher depressive scores. And this means that higher triglycerides means higher depressive scores. So basically,
You have 5 minutes left.
thanks. So lower total cholesterol measurements a study conducted by Rabe and colleagues indicated that low cholesterols were associated with severity of depression, because the brain is an important, cholesterol is an important organic molecule, and the brain is a cholesterol-rich organ, and cholesterol is responsible for managing neurotransmitters such as serotonin, which stabilizes mood and feelings of happiness. So low cholesterol levels may influence serotonin functioning by lowering the number of activated serotonin receptors. Then research regarding the relationship between LDL and depression is inconsistent, but research found that lower LDL was associated with more severe depression. So generally, having high levels of HDL cholesterol, which is good cholesterol, and low levels of LDL is ideal in terms of cardiovascular disease. But research has shown that there is a relationship between very low levels of LDL cholesterol and increased risk of developing mood disorders such as depression. Then there's also been varied data regarding whether triglycerides are associated with depression. A study performed by the Netherlands Study of Depression and Anxiety found that triglycerides are higher in patients with major depressive disorder. And the link between high triglycerides and depression involves insulin resistance. And insulin is a hormone produced by the pancreas that regulates the metabolism of carbohydrates. Insulin resistance could impair the functioning of the hypothalamic pituitary adrenal axis, which controls the brain's response to stress. So this regulated axis will affect the regulation of hormones, and this will lead to abnormal stress responses, and this will lead to depressive symptoms. The brain insulin also regulates dopamine pathways. So disruptions will affect the brain's motivation and rewards mechanisms, and this will lead to depressive symptoms because of the inability to feel pleasure pleasure or satisfaction. Then blood pressure measurements and depression, there was significant moderate association between MADRS and systolic blood pressure in males, and this is because males generally have a high blood pressure compared to females, which starts at puberty and continues through adulthood until women begin menopause. And then depression and the extended questions. So both BDI and MADRS were associated with how long it takes to fall asleep, and most participants reported that it takes more than 60 minutes to fall asleep, which is pretty long. So most people who suffer through depression have sleeping problems, and this often aggravates depressive symptoms because those who are depressed struggle to regulate their emotions. So a few limitations and suggestions. It was a cross-sectional study. There were few males, and the sample size could have been a bit too small. The BDIs were self-reported, which could have resulted in bias. And then we could have also included financial status and environmental factors, as well as smoking and exercise. And then just to conclude, depression is prevalent among university students, and factors influencing mental health should be addressed. And further research is required to indicate a causal relationship between depressive symptoms and variables. And thank you, special thanks to NRF, as well as my supervisors, Dr. De Smit and Prof. Ulufse, for their guidance and help. Thank you.
Thank you so much for that presentation. I think as people in the higher education context, looking at depression amongst university students is an incredibly important topic. Thank you so much. Can I ask the last five, well, the first five presenters of today all have their videos on, as we're going to enter a short quick Q&A session. And the attendees, please take the opportunity to ask any questions you have in the Q&A section. So can our first five presenters please all put your presentation and your videos on? I see that there are two questions in the Q&A so far. I'll start with the first one, which is for Dr. Rimini. Did you make any suggestions as to where, more or less, or at or during which developmental stages or age ranges prevention strategies should be targeted for the 4 clusters of disease?
So the one thing we found was that definitely among the elderly and among women, there were higher prevalence of disease. But we can't really do recommendation for what sort of intervention should be, that would require more research. I'm sure people are doing research on it at the moment as well. So yes and no. Thank you.
Great. And then there's another question just for our last presenter. This person has noted that you skipped the methodology used in the data analysis, and with control and treatment groups, they were expecting to hear a discussion on the difference in difference technique. You can consider difference in the data as has been analyzed using a different technique. So do you perhaps want to respond to that?
We didn't actually use a different technique. Basically, all the participants came at the same time, or they were scheduled for data collection. Because it wasn't a blind trial, everyone was basically treated the same, but I do understand why they expected a difference in technique.
Great, thank you. Someone has queried, yes, there is another presenter who is going to go after the Q&A session, just as we're going to even out the blocks. So we've got a couple of different blocks. Are there any other questions from any attendees? I think a question that I had, again, for our last speaker, Ms. Kamaldeen, I was curious at what time of year you did your data collection with university students, and wondering if that was maybe close to exam time, how that might have affected the depression scores.
We actually collected in September, so I guess it was pretty close. It's about a month and a half maybe to exams. But we were also pressed because of COVID, so the whole study was basically determined by COVID, and then we got delayed, so we had to do data collection when we could actually. So yeah.
That's interesting, and I'm sure COVID times, people who would previously not have dealt with mental health issues probably had quite a lot of that come up for them, especially with loss in their families as well.
Yeah.
Any other questions or comments from the panelists as well that you might want to comment on?
Can't hear you, Janine.
Thank you. Sorry, someone has raised their hand from one of the attendees and would like to ask a question verbally. You're welcome to.
Yes. Good morning. It's Peter speaking. The question I just wanted to ask the last presenter how she analyzed the data, so that this is her thesis, and just maybe let's get how she did the data analysis. If there's some input that one can contribute to help her beef the analysis in such a way that the paper can easily be accepted for publication.
Hi. Do you mean with regards to like the programming SPSS? We just
No.
used correlations and associations between the variables.
Because I heard you talking about treatment and control group, right?
Just the control and whether they were depressed. So we didn't have any treatments. It was either they were depressed or they were not depressed.
Yes. Yeah, that's, I think, also something that you can consider. You can also consider this other quasi-experimental design techniques, which you can use to check, to do the analysis. Like if you may consider propensity matching scores, it will still be another good technique for you to use. I think it will be a little bit of work for you, but it will be a good technique if you can consider it. It will help your work very well.
Sorry, can you just say that technique again?
Propensity matching technique, propensity score matching.
Okay, thank you so much for that advice.
Okay, you're welcome. Yes.
Great. I think that's all of our questions that we've had so far. I haven't seen any other questions. If there are perhaps any in the attendees chat, I can't see that on my side. But I don't see any others in the Q&A box. If there's nothing else, then thank you so much to our first 5 presenters. We're going to move on to our next block under the health and understanding the burden of disease. May I please have the bio for our next speaker? One back, it should be Dr. Boyson. Yes, Dr. Boyson is a postdoctoral fellow at the Institute for Microbial Biotechnology and Metagenomics. She completed her undergraduate and postgraduate degrees at the University of Stellenbosch. Both her master's and doctoral degrees focused on isolating novel antimicrobial peptides from entomopathogenic bacteria. For her postdoctoral fellowship, her focus is on isolating novel antivirulent and antibiofilm factors from marine bacteria. Over to you, Dr. Boyson. We can see your presentation.
Good day, everyone. Welcome to my presentation titled Novel Bio-Based Technologies for Sustainable Water Management. I'm Alzan Boyson, and I'm from the Institute for Microbial Biotechnology and Metagenomics. Water cooling towers are major uses of water worldwide, and increased industrial development has led to a greater demand for water and natural resources, particularly in threshold countries such as China, India, and South Africa. The high nutrient load, warmer than ambient temperature, neutral pH, and continuous aeration make water cooling towers the ideal environment for many pathogenic bacteria. Microorganisms in cooling towers attach to surfaces and develop into biofilms. These biofilms are highly structured microconsortia that are immersed in a self-produced extracellular matrix. Biofilms in cooling water towers also have a negative financial impact. They cause accelerated metal corrosion, increased resistance to heat transfer, and increased fluid frictional resistance, effectively decreasing the efficacy of the cooling tower. Traditionally, a combination of continuous oxidizing biocide and periodic doses of non-oxidizing biocide is used to treat biofilm formation in industrial water systems. Chemical surfactants have become essential constituents to enhance biocide activity. In particular, the combination of chemical surfactants with biocides offers significant improvement as these surface active compounds form micelles. These micelles act as wetting agents by increasing the penetrating properties of surfactants, making them more effective at disrupting the biofilm matrix. However, these added chemicals are toxic to the environment and therefore represent an ecological hazard. Increasing environmental legislation puts pressure on the water treatment industry to find alternative sources to significantly reduce the concentration of chemical biocides used. One proposed solution is using biosurfactants as alternative biocides or in co-formulation with chemical biocides. Biosurfactants are amphipathic bioactive compounds from natural sources and are an alternative to petroleum-based surfactants. Advantages associated with biosurfactants include lowered toxicity, high specificity, biodegradability, superior foaming properties, improved effectiveness and stability at extreme temperatures and salinity, and in addition to reducing surface tension, some biosurfactants have inherent antimicrobial and dispersal activity. Biosurfactants are classified according to the chemical structure of the hydrophilic bed group into different classes. This project focuses on the lipoamino acid lysoornithine lipid, or LOL. LOL is produced when an ornithine is acylated to a 3-hydroxy fatty acid by ornithine acyl ACP N-acyl transferase or OLSB, while an acyl carrier protein is responsible for linking the fatty acid to the acylated ornithine. The OLSB is responsible for producing the LOL used in this project was identified in Buffalo Strait Lake sediment contaminated with both diesel fuel and is patented in both Europe and South Africa. 4 LOL species were identified in the supernatant of an E. coli strain expressing the OLSB and ACCP. For this project, we have linked with YDX as our industry partner to help with achieving Sustainable Development Goal 6, clean water and sanitation, and Sustainable Development Goal 13, climate change action. YDX developed a proprietary environmentally friendly biocide, Decont A, for the treatment of industrial cooling towers, effluent water, sewer effluent, and recovery water. We are also working in collaboration with the CSIR for the mass production of LOL. In addition to antibiofilm activity, LOL is also being tested for neuroprotective properties and emulsification properties by other industry partners. This brings us to the aim of this project, which is to develop a novel biocide biosurfactant formulation to eradicate the formation of biofilms formed in industrial cooling towers. In order to achieve this aim, we identified 3 objectives. The first is to optimize the overexpression of LOL in E. coli. The second is to determine the minimum biofilm inhibitory concentration of the Decont A LOL co-formulation in high throughput assay. And the last is to test the antibiofilm properties of the Decont A LOL formulation on biofilms formed under continuous flow conditions. I will briefly go through the materials and methods as well as the results for each of these objectives. For the first objective, we genetically modified an E. coli to express an SL-ACCP synthetase enzyme, OLSB, and ACCP. This strain was used for all subsequent optimization assays. The expression conditions, namely temperature, medium pH, induced concentration, and L-ornithine concentration, was optimized using fermentation experiments. The cell cultures were clarified using a centrifuge, and the clarified second agent was analyzed on an HPLC. The optimization in these studies indicated that LOL was optimally produced at 25 degrees Celsius, a medium pH between 7 and 8, and an IPTG concentration of 1 millimolar, and L-ornithine concentration of 20 millimolar. In addition to an increase in LOL production, we also noticed a shift in the train profile when different L-ornithine concentrations were used. For instance, at the lowest L-ornithine concentration, 2 will shift towards a longer chain length LOL being produced, while at 20 millimolar shift to the shorter chain lengths for C. We also identified 2 additional chain lengths, C12 and C14, when 200 millimolar L-ornithine was used for doing the expression. This indicates that L-ornithine concentration can be used to control the profile of the chain lengths produced. In objective 2, we evaluated 3 sources of water collected by our industry partners from industrial cooling towers at a power generating facility, a mine, and a metal refinery. The water was tested for biofilm forming potential using high throughput 96-watt assays. The high throughput 96-watt biofilm assay was also used to determine the minimum inhibitory concentration of both LOL and Decont A. The next step was to co-formulate Decont A and LOL. Decont A and LOL was mixed in different ratios, and the stability of the formulation was analyzed in HPLC. Finally, the biofilm minimum inhibitory concentration was determined for Decont A LOL co-formulation. The water was used both as an inoculant and a growth media. The water collected from cooling tower pond 1 had the highest biofilm forming microbial community, and the biofilm was formed within 4 days, and within 7 days, biofilm thickness was doubled. In contrast, even after 7 days, barely any biofilm formed water from cooling tower pond 2 and 3 was used. Thus, water from cooling tower pond 1 was used for all subsequent assays. While the minimum biofilm inhibitory concentration of Decont A was 2 ppm and for LOL was 20 ppm. Once the decant A and LL was combined, the efficacy was significantly increased as the minimum inhibitory concentration was reduced to 0.5 ppm decant A and 10 microgram per mole LL. In objective 3, the water from the cooling tower pond 1 was sterilized by filtration, and a portion of the water was kept aside and used as an inoculant. The biofilm was formed under continuous flow, and the biofilm formation was monitored using a carbon dioxide measurement system. A portion of the effluent was used for colony counts. The effluent was also collected, and the metagenomic DNA was isolated and sequenced using a nanoform sequencer. After sequencing, the genomes were assembled and analyzed to cracking 2. As mentioned, biofilm dispersal was monitored through colony counts, while the metabolic activity was monitored with the CO2 analyzer. I'll be discussing the results of the CO2 analyzer in this presentation. Stabilization of the biofilm was only achieved after 288 hours or 12 days. This is significantly slower when compared to biofilm formation and stabilization of homogeneous genome, homogeneous biofilms in the reference studies used for the planning of this project. Once CO2 production stabilized, the biofilm was either left untreated or treated with LL, decant A, or decant A plus LL. You'll see we used a significantly higher concentration in this assay. This was due to when we did preliminary continuous flow assays, we found that a higher concentration of the treatment is needed to inhibit or affect biofilm development. And we also noticed an increase in metabolic activity immediately after treating the biofilm with the 60 ppm decant A and 60 ppm decant A plus 10 microgram per mole LL. This could be due to an increase in expression of efflux pumps. The same increase is not observed for the untreated biofilm and the biofilm treated with 10 microgram per mole LL, further indicating that the increase might be due to stress. Shortly after treatment, a decrease in 4% was measured in CO2 for biofilm treated with decant A, and a decrease of 8% for biofilm treated with only LL. And a decrease of 23% was seen for the biofilm treated with the decant A LL co-formulation. A difference in the colonies after treatment was also observed. Unfortunately, a complete biofilm eradication is not observed since CO2 levels recorded did not return to the baseline of 400 ppm.
You have 4 minutes left.
Although biofilm eradication is not observed after biocide treatment, the profile of the cultural community indicated that the shift in the community occurred in response to these treatments. Therefore, evaluating the microbial community pre- and post-treatment could represent an additional level of analysis to describe the effect that the treatments have on the biofilms. The microbial community's pre- and post-treatment for the 4 experimental treatment groups were analyzed through metagenome sequencing. After treatment with LL, a significant increase was seen in the concentrations of Streptomyces cerevisiae and Bacillus in the effluent, and a significant decrease in Sphinxomonidaceae. After treatment with decant A, a significant increase was seen in Rhizobiaceae, Commonadaceae, Pseudomonidaceae, and Streptomyces was observed in the effluent, while a significant decrease in Sphinxomonidaceae and baby Rhizobiaceae was observed. After treatment with decant A and LL co-formulation, a significant increase in Rhodobacteriaceae and Pseudomonidaceae was observed in the effluent, while a significant decrease in Sphinxomonidaceae, Calobacteriales, and Bacillus was observed. Numerous genes related to antibiotic resistance was also identified in the metagenomic datasets. Genes related to resistance against ciprofloxacin, vanadixic acid, beta-lactam antibiotics, phenylpheniramine, and chlorpheniramine was identified in the metagenomic datasets, generated from the DNA isolated from the effluent pre-treatment, indicating that the bacteria that stopped from the biofilm during the initial attachment and maturation phases were resistant to a wide range of antibiotics. In addition to the previously mentioned genes related to tetracycline and tetracycline derivatives resistance was also identified in the effluent after treating with LL and decant A plus LL. Once again confirming our earlier statement that treating with LOL and D.A significantly changed the microbial community in the biofilms, while no genes related to antibiotic resistance were identified in the biofilms treated with a control or D.A, indicating that once the biofilm matured, the bacteria that is responsible for antibiotic resistance phenotype of the biofilm was not stopped after the control treatment and was not disturbed when the biofilm was treated with D.A alone. Surfactants have long been used in combination with biocides to improve antibiofilm activity, but the increase in environmental legislation necessitates the introduction of more environmentally friendly antibiofilm agents. In this study, we found that high-throughput 96-well assays can be misleading when determining minimum inhibitory concentrations, and treatments needed to inhibit biofilms formed under continuous flow react differently to the treatments. We also found that when combined with LOL, the activity of D.A was improved by 19%. Significant shift in the microbial community observed between the different treatment groups, indicating that treating the biofilm with D.A and LOL had significant influence on the microbial community present in water. Lastly, a significant increase in bacterial resistance to antibiotics were observed after treating the biofilm with D.A and LOL, indicating that co-formulation can target and disperse these bacteria in a biofilm. I'd like to acknowledge the following people and industry partners for their help and funding. Thank you. Any questions?
Great, thank you so much, Dr. Boyson, for that very interesting presentation. I am going to ask for our next presenter's slide, bio slide, please. And just a reminder to everyone to please make use of the Q&A box to ask any questions you have, and we will then do the Q&A after the 5 presenters have presented. And there we go. Our next presenter is Ms. Robin Abrams. She is a postdoctoral fellow at the Institute for Microbial Biotechnology and Metagenomics. She completed her undergraduate and postgraduate degrees at the University of Stellenbosch. This is a duplicate from the previous slide, I believe. Or that's just very similar. I think it's just very similar. Okay. At the University of Stellenbosch, both her master's and doctoral degrees focused on isolating novel antimicrobial peptides from entomopathogenic bacteria. Postdoctoral fellowship, she focused on isolating novel antivirulents. I think it might be an incorrect slide. I think that's a duplication.
Sorry, Janine. Dr. Rishka Adam. Oh, sorry. Rishka Adam is Dr. Adam.
Okay. We don't have a bio slide for Dr. Ahmed.
So Dr. Adam can just continue.
Okay. Dr. Ahmed, you are up next. Please will you share your screen?
Okay, I'll do that. I think I was supposed to be at 11. I'm just double checking. Let me get all my things.
Yes, we are a little bit ahead of time because the previous Q&A was a bit shorter and we had a panelist pull out.
Okay, so if you could just give me a second and I will be ready in very, very soon.
Sure.
Okay. Share my screen. So just let me know if you...
We can see your screen, but not the presentation yet.
Can you see me? Okay, I'm ready to go.
We can see your presentation. Thank you. You may go ahead.
Okay. Good morning, colleagues, and thank you for allowing me the opportunity to present my research on hypochlorous acid as an alternative disinfectant agent against Enterococcus faecalis. So let's get started. In dentistry, bioaerosols refer to tiny airborne particles or droplets that contain microbiological materials such as bacteria, viruses, and fungi. The composition of the bioaerosols can vary depending on the patient's oral health and the specific dental procedures being performed. It is primarily generated when high-speed instruments such as handpieces and ultrasonic scalers come into contact with tooth structure, saliva, blood, or dental restorative materials that are present in the oral cavity. These bioaerosols can either be inhaled or can settle on surfaces in the dental surgery, leading to the potential transmission of infectious agents that can pose health risks to dental healthcare workers and patients alike. So, of the pathogens that we can focus on in dentistry, I decided to speak about or to study Enterococcus faecalis. It is a gram-positive facultative anaerobic bacterium commonly found in the GIT, but in the dental context, it's often associated with persistent root canal infections. It can switch between aerobic and anaerobic metabolism depending on the availability of oxygen in the environment. E. faecalis possesses certain virulence factors that enables it to cause infections and has the ability to adhere to tissues and to form biofilms. Biofilms, as we know, are communities of bacteria enclosed in a protective matrix, making them resistant to the immune system and antibiotics. It is commonly found in the oral cavity, and clinical studies have reported the prevalence of E. faecalis in dental splatter on dental instruments, the dental chair, and surfaces and countertops close to the patient. So what are the implications for healthcare settings and the importance of the study in the theme health and understanding the burden of disease? We're all aware that there is resistance developing to antibiotics, and in light of that, it makes sense that there would be resistance of elimination developing as well. Dental staff can become vectors for cross-contamination in several ways if proper infection control measures are not followed. This usually includes insufficient hand hygiene, contaminated instruments, improper glove usage, and inadequate surface disinfection. Surfaces in the dental surgery, like the dental chairs, countertops, light switches, must be properly cleaned and disinfected between patients. However, it is not always possible to disinfect all these surfaces with the traditional methods, and in some instances, inadequate training or a slapdash approach can result in the transfer of microbes. E. faecalis is one of those microbes, and it is known for its ability to survive and persist in harsh environmental conditions because it has the ability to produce the biofilms we chatted about, and this forms the physical barrier that does not allow the disinfectant to penetrate. Studies have shown that there is evidence of resistance to the usual disinfectants like ethyl alcohol, and that is why continuing the research into E. faecalis and the methods of elimination is of an importance in the health sector. One of the challenges we face in the health sector is the exponential development of resistance to traditional disinfectants. Hopefully, this study will provide some solutions. So before we go into what I would like to do, let's just recap on what is the traditional methods of disinfection in a dental surgery. It involves the wearing of PPE, your personal protective equipment, your hand hygiene, and the use of high volume suction systems, instrument sterilization, water quality management, and surface disinfection. So I'm sure you guys are getting that this is where I'm going to be focusing my study on. As previously mentioned, certain surfaces are hard to reach and cannot always be decontaminated using the current practice of spray and wipe, hence the need to find alternative surface disinfection methods. One of the main disadvantages of the current protocols is that disinfection is dependent on the skill and the tenacity of the operator and reaching these contaminated surfaces that might not be visible. With this in mind, this study will look at hypochlorous acid in a vapor form as an alternative. So what is hypochlorous acid? Hypochlorous acid has gained popularity after the COVID-19 pandemic as a potent and environmentally safe disinfectant with a wide range of efficacy against several human pathogens. It is a weak acid that forms when chlorine dissolves in water, and it has powerful antimicrobial properties. This chlorine-based disinfectant can penetrate the bacterial cell wall, causing damage to the cell membrane and interfere with cellular processes, resulting in the inactivation of the microorganism. Literature reports that hypochlorous acid can penetrate and cause biofilm disruptions, and this is especially advantageous when researching methods of eliminating the biofilm-producing pathogen, such as E. faecalis. The aim of the study was to investigate a commercially available disinfectant that contains hypochlorous acid in a novel manner to deactivate the pathogen E. faecalis in various challenge mediums that mimic the dental scenario. So I realize that's a mouthful, but just bear with me. It will make sense once you see the actual study. The null hypothesis is that hypochlorous acid will eliminate the E. faecalis regardless of the challenge mediums used. So for my methodology, one of the most important things for me was to find a detergent that was readily available. So the choice of the disinfectant for this study was based on the principle that all dental surgeries use a commercially available waterline disinfectant, and it would be beneficial to use the same product instead of having to purchase an additional disinfectant. This is especially advantageous for us since it is environmentally friendly, number one, and does not require an additional expense. The IvoClean Dental Unit Waterline Disinfectant is one such product designed for disinfecting the dental waterlines of a dental chair. And hypochlorous acid is the active ingredient and was used in a novel form in the form of vapor.
You have about 5 minutes left.
E. faecalis was the bacteria or the pathogen of choice based on dental splatter research. It was reconstituted in the lab using luria broth. A 24-hour E. faecalis isolate was then standardized in phosphate buffered saline to a 1.0 Macfarlane standard. 10 milliliters of the standard was then mixed with 10 milliliters of the challenge media in 96 well plates. The media of choice for this study was based on the principle that all dental surgeries, let's get this right. The media of choice or the solutions was based on the nature of the pathogen E. faecalis. These were appropriate culture media and sterile solutions, which is essential for accurate and reliable results. Some were chosen to be neutral mediums as controls. Others had nutrients within it to maintain the physiological conditions necessary for cell survival. So the mediums that I chose are listed on the slide. It was distilled sterile water, phosphate buffered saline, yeast peptide dextrose agar, brain heart infusion, tryptophan soy broth, and these were all placed in a 96 well plate. So what was the novel way that I approached this research? The idea was to use a vaporizer. So the vaporizer used in the study was a standard cold vaporizer device that dispensed a fine mist in a controlled manner. In order to assess the efficacy of the disinfectant, the 96 well plates was placed within the fume cupboard and was vaporized using the IvoClean Dental Unit disinfectant for 60 seconds. The 60-second period was based on the size of the fume cupboard and in the aim of making the contact period relatable to a dental clinic so that we don't lose time in between patients. The premise of this technique was that the generation of vapor allows for a fine mist to settle over the clinical area and in doing so eliminate pathogens that have settled on the surfaces. After the well plates were exposed to the vapor in the fume cupboard, XTT cell assay was added to quantify cell viability and proliferation. XTT is a colorimetric assay that measures the activity of cellular enzymes that reduces the XTT to an orange-colored formazan end product. Thereafter, the cells were incubated with the XTT solution for 24 hours, and readings were taken at 2 and 24 hours with a spectrometer at a wavelength of 450 nanometers. The most important part of today's chat for me was the conclusion. The analysis of the data concluded that there was evidence that hypochlorous acid effectively caused microbial reduction or log kill of E. faecalis in distilled sterile water PBS, YPD, BHI, and tryptone broth. The overall conclusion reached was that hypochlorous acid has microbial reductions, and no challenge medium had a significant microbial reduction over another. Interestingly enough, though, there was no significant difference between the challenge medium at 2 hours. However, a difference was found when we checked it at 24 hours with regards to the log kill. So this can be attributed to the composition of the specific challenge medium and was identified as one that contains the nutrients which the pathogen could then feed on and form biofilms. I can then conclude that the log kill of the pathogen is influenced by the time between splatter contamination and disinfection. So what does this mean for dentistry and for the health sector? The literature has provided evidence that hypochlorous acid is a non-toxic, safe, and inexpensive disinfectant, and with the flexibility when it comes to application methods. The study has shown that hypochlorous acid in the form of IvoClean waterline disinfectant, which is readily available, can eliminate E. faecalis in the various mediums. More importantly, it is now a multi-purpose disinfectant, since it can clean water lines and surfaces as well. Not only can this be added to the dental clinic regimen for disinfection, it will play a role in reducing the development of resistance against the current disinfectant agents. What I'm most excited about is that it can reach those places that are hard to reach, which means the vapor is the non-traditional method of disinfecting. Plus, it is not dependent on the skill of an operator, which means that we don't have to manage staff with regards to disinfection. The study once again reinforces that it is the responsibility of dental staff to equip them with the necessary skills and knowledge to maintain a safe and clean, sterile environment. Ultimately, we should be enhancing the quality of patient care and overall public health, and to look for alternatives because we have responsibilities that extend beyond the surgery walls. Thank you.
Thank you so much, Dr. Ahmed, for sharing those very interesting applied findings for your field. And it will be very exciting to see how you're able to take this forward in terms of recommendations for actually using this in the field. Thank you so much for sharing that. Our next presenter's bio slide.
It does.
I believe our next presenter is Ms. Abrams. May I please have her bio slide, or is that not available? I think we had an issue with that bio slide, so I will just hand over to our next presenter, Ms. Abrams, to start her presentation.
Good morning all. Thank you for the opportunity to present today. I am Robin Abrams and I will be presenting a study on the factors determining women's time taken to reach healthcare facilities in South Africa, the case of the Eastern Cape province. The outline of the presentation is as follows. We'll begin with the introduction and context, the research methodology, then the results, and the discussion and conclusion. This presentation is based on the paper that I submitted to the Journal of African Population Studies. This was written alongside my supervisor, Dr. Philomene Singiyumva, another PhD student, Mr. Guillaume Showers, and then Prof. Sisang Gabaza of Women and Gender Studies. Moving on to the introduction and context, the health and well-being of a population depends on having access to healthcare. Access to healthcare facilities is essential for well-being and for socio-economic development. In terms of distance, using distance alone to measure access in developing countries may not give a complete picture, as it does not capture the potential transport difficulties that are likely to be present. Travel time can be considered very important in measuring access, as it reflects both the geographical distance to healthcare facilities and the difficulties associated with accessing healthcare. And the study is consistent with this idea. Travel time to healthcare facilities is one of the key measures of accessibility to healthcare. And against this background, the study shows that socioeconomic and demographic characteristics play a very important role in the time it takes women in the Eastern Cape to travel to healthcare facilities. Traveling longer times to healthcare facilities can make people more reluctant to seek medical care when they need it. And in traveling to healthcare facilities, the rules in Cape Province and the broad dispersion of healthcare facilities prevent women of rural regions from accessing healthcare facilities as easily as women in urban areas do. In this province, a legacy of inequitable resource allocation under the apartheid era is still found within the framework of the healthcare system, and the wide, unequal, and inequitable distribution of resources between metropolitan and non-metropolitan areas is still observed in the Eastern Cape, and it's evident in the time taken to travel to healthcare facilities among women who seek medical care when they are ill. Moving on to the data and methods. The setting of the study is the Eastern Cape Province, and the sample of the study was extracted from the master sample of the General Household Survey of 2018. And this primarily included women who were heading households from the age of 12 years and above, residing in the Eastern Cape. The study population was divided into categories based on their area of residence, which are metropolitan and non-metropolitan areas. For the study, there were 6 variables of interest. The dependent variable was the travel time to healthcare facilities, and then the independent variables were population group, level of education, employment status, income, and area of residence. Since the data of the General Household Survey 2018 was collected through Statistics South Africa, it was extensive, so we used SPSS version 28 to analyze the data. The data was analyzed through descriptive statistics and bivariate analysis through cross-tabulation. Finally, logistic regression was also performed to identify the factors contributing to travel time to healthcare facilities among those women across metropolitan and non-metropolitan areas. Okay, so moving on to the results. This is the results for the cross-tabulation between female characteristics and the travel time to healthcare facilities. I will walk you through some of the key findings. The characteristics of women were analyzed against 4 travel time categories, which were less than 15 minutes, 15 to 29 minutes, 30 to 89 minutes, and then 90 minutes and more. In metropolitan areas, Black women accounted for a large proportion of women that traveled less than 15 minutes. Most women, irrespective of ethnicity, indicated that they traveled between 15 to 29 minutes when seeking medical care. And then in non-metropolitan areas, the study found that Black women accounted for the majority of women who traveled less than 15 minutes. A small percentage of women indicated that they traveled more than 30 minutes to healthcare facilities, of which the majority was Black women. Women who were educated up to secondary level, with the majority of women that traveled less than 15 minutes to healthcare facilities, and a small number of women who were educated up to tertiary level traveled less than 30 minutes to healthcare facilities. In non-metropolitan areas, the majority of women with secondary education traveled between 15 to 29 minutes to healthcare facilities, and those with primary education were among the majority of women that traveled more than 90 minutes to healthcare facilities. Among women who traveled less than 15 minutes to healthcare facilities, the majority were economically inactive women, followed by employed women and then unemployed women. And regarding non-metropolitan areas, economically inactive women were the majority of women that traveled less than 15 minutes to healthcare facilities. looking at the relationship between travel time and household income in metropolitan areas, women in high income and low income households accounted for the majority of women who traveled less than 15 minutes to a healthcare facility. A small percentage of women in low income households constituted the majority of women who traveled more than 90 minutes when seeking medical care. Then in non-metropolitan areas, irrespective of monthly household income, the majority of women traveled less than 15 minutes to healthcare facilities. However, traveling between 30 to 89 minutes was more common among no income and low income households. Then regarding the area of residence of women, in metropolitan areas, most residents that traveled less than 30 minutes to healthcare facilities were urban residents. And looking at non-metropolitan areas, women in rural areas were more likely to travel between 15 to 29 minutes to healthcare facilities than women in the urban parts of non-metropolitan regions. Moving on to logistic regression, regarding the factors determining traveling less than 30 minutes to healthcare facilities, the study found that living in high-income and middle-income households increased the chances of traveling less than 30 minutes to healthcare facilities in metropolitan areas. Women who were residents of urban areas were less likely to travel less than 30 minutes to healthcare facilities than women in rural residents. In non-metropolitan areas, living in high-income and middle-income households increased the odds of traveling less than 30 minutes to healthcare facilities. Women that were residents of urban regions were more likely to travel less than 30 minutes to healthcare facilities within non-metropolitan areas than women in rural areas. Then regarding the factors determining traveling more than 30 minutes to healthcare facilities, in metropolitan areas, the study's findings indicated that living in high-income and middle-income households decreased the chances of traveling more than 30 minutes to healthcare facilities. The findings also revealed that colored women have a decreased chance of traveling more than 30 minutes than white women, and living in urban areas increases the odds of traveling more than 30 minutes to healthcare facilities. When we look at non-metropolitan areas, the study found that living in high-income and middle-income households in non-metropolitan areas decrease the odds of traveling more than 30 minutes to healthcare facilities. And it was observed that living in urban areas decrease the chances of traveling more than 30 minutes to healthcare facilities. Moving on to the discussion and conclusion. The study found that Black women constituted the majority of women that traveled more than 30 minutes to healthcare facilities. The increased travel time among Black women as compared to colored women or white women is traced back to the apartheid era and the history of segregation within the Eastern Cape province, where Blacks were forcefully relocated to the rural plains of the Eastern Cape province, and they were left with limited service delivery, like inadequate infrastructure and a severely undersourced healthcare system. The study found that women in low-income and no-income households were among the majority of women that spent an increased time traveling to healthcare facilities as compared to high-income households, where income is concerned with traveling to healthcare facilities. When women have to resort to walk into healthcare facilities, this increases their travel time when they are seeking medical care. In metropolitan and non-metropolitan areas, a similar pattern emerged regarding employment status. Economically inactive women were more likely to travel more than 30 minutes to healthcare facilities as compared to either employed women or unemployed women. And this is a result of available financial resources, or the lack of available financial resources to assist in accessing healthcare facilities. Income and employment were influenced by education, in as much as high levels of education attainment were directly proportional to high levels of monthly income and increased employment opportunities, of which the opposite is also true. Therefore, women with high levels of education were found to have a decreased travel time to healthcare facilities. And then
You have 4 minutes
lastly,
left.
okay, thank you. And then lastly, residing in rural areas. was associated with longer travel times to healthcare facilities, and this was attributed to the distribution of healthcare facilities and then the availability of services required by women who were seeking healthcare when they were ill. Thank you very much.
Great, thank you so much, Ms. Abrams, for sharing something that actually is an issue that a large portion of our very vulnerable people in South Africa had to deal with, that challenge of accessing healthcare services and the time taken for that. Just a reminder to our attendees to please make use of the Q&A section to add any questions that you have for our panelists, and we will pause for a Q&A after our fifth presenter. Our next presenter is Prof. Swart. May I please have that bio slide? Prof. Swart is a registered dietitian nutritionist with the HBCSA and part of the Department of Dietetics and Nutrition at the University of the Western Cape. The postgraduate qualifications and area of specialization is in public health nutrition, with a focus on the prevention of all forms of malnutrition through nutrition policies and programs, as well as the evaluation of such policies and programs. She serves as the nutrition program leader with the DST NRF Center of Excellence in Food Security. Prof. Swart, thank you so much for joining us from the US, and over to you.
Thank you very much. I will share my screen. You can see the screen?
We can, yes, thank you.
Greetings from New York, and my apologies for appearing on your screen a little bit later than planned, but I will blame the time difference between the different regions. Before I start my presentation on the potential effect of front of pack labeling to reduce disease burden in South Africa, I just need to declare that I do not hold any funding from industry sources. Globally, dietary intake does not meet the World Health Organization recommendations for healthy diets in any of the regions. You can see on the right-hand side the 100% mark being exceeded for most of the regions, and the Lancet review found all regions to be excessive in their intake of animal protein, as shown for red meat, eggs, poultry, and fish on the slide. Note, the green bar in each of these food categories represents sub-Saharan Africa. Yet, in most regions, consumption of vegetables, fruit, legumes, whole grains, and nuts are inadequate. A review of the food consumption of South Africans in the period between 1997 and 2019 confirmed the Eat Lancet conclusions for South Africa. In actual fact, the consumption of fruit and vegetables decreased by 40% in this period, and remember that it started out only at 50% of the World Health Organization recommendation. Together with that, nut consumption is almost negligible at 1 gram per person per day, whilst consumption of legumes also halved in this period. On the somewhat positive side, animal protein increased. However, we are now at this stage exceeding the World Health Organization recommendation, and this has got some implications for the climate change and environmental impact. In addition to the health consequences of the healthy food consumption that we're recommending, there are also what we call discretional foods, and that would include aspects such as, or products such as plain sweet biscuits, salty snacks like potato crisps, sugar-sweetened beverages. Unfortunately, consumption of these products increased between 100 to 250% over the period 1999 to 2019. So, in essence, the South African diet can be defined as commercially driven or retail driven, because almost 95% of population purchase all of their food consumed from either supermarkets or other food outlets, plus the growing consumption of fast foods contribute to an increase in healthcare cost, driven by an increase in morbidity and mortality of non-communicable diseases. And the pathway to most of these health effects is through the increase in obesity. There is a global epidemic of obesity, but when you look at different countries and compare rates, you can see that South Africa not only has got very high rates of obesity for women in the red line and men in the blue line, but that our trajectory for children is quite worrisome. Obesity is a causal factor in most non-communicable diseases like diabetes and cardiovascular disease. Even in cancer, it is expected that obesity will exceed or smoking as the main risk factor for preventable cancer. And we know that 80% of our healthcare costs are related to non-communicable diseases, yet only 3% of the budget is spent on prevention. International best practice has identified 4 policy areas to work towards a healthy food environment, and specifically also focusing on attempts to reduce the obesity pandemic. And those 4 areas include a taxation on sugary sweetened beverages, which we had implemented in South Africa in 2018, front of pack labeling, that is compared to the back of pack labeling, which has been part of regulation for a while, marketing restrictions, as well as reformulating of food towards more healthy options. My presentation today will focus on front of pack labeling, specifically reporting on work that we have done between 2018 and 2022, and which culminated in the draft regulation or inclusion in the draft regulation on food labeling that was published on the 21st of April 2023. The intention of front of pack labeling is to inform consumers at the point of sale, and there are different types of front of pack labels that you can find. There are reductive types. On the right-hand side, you see the guideline daily amounts, or GDA as we refer to it. And then on the left-hand side, you see interpretive kind of labels. You see the examples there of the traffic light, and then the warning labels being used, which are nutrient-based systems on the left-hand side. You also find summative systems where the decision is being made by looking at the positive and the negative of the different nutrients and giving one value statement on the food displayed to indicate an overall judgment. However, the problem with summative systems is that the positive nutrients, such as micronutrients that might be added to the food, does not counter the effect of the negative nutrients. So it's actually an unequal sum that you are trying to do if you use summative systems. For the purpose of our research, we pursued a nutrient-based system as well as the reductive system, which we then tested in a research project. But leading up to that specific project, we first developed nutrient profile model to indicate cut points for products to be indicated as containing excessive amounts of nutrients of concern. The nutrients of concern that have been associated with non-communicable diseases are sodium, total fat, saturated fat, and then also included on the request of the Department of Health, non-sugar sweeteners. We tested the different labels, and remember I mentioned 3 types of labels. So on the left-hand side, I'm just showing one of the products so you can see what it looked like on the products. There is a yogurt with the GDA on the left-hand side, followed by a yogurt with the warning label, and then next to it, there's a yogurt with the multiple traffic light, where different nutrients and the levels are indicated by colorful labels, with red if it's too high, excessive in a particular nutrient, green if it is not excessive in a nutrient of concern, and then amber if it is in a particular range where there is need to be caution. You see the results of the randomized control trial that we conducted in a population of about 2,000 participants randomly selected to represent the socio-demographic profile of the country. And participants were shown the product without any label, asked questions about that particular product, the unhealthiness of the product, and whether the product is high in nutrients of concern. And then in a repeat process, they were shown the same product, but now appearing with one of the labels in a randomized allocation to one of these 3 label conditions. And you can see wherever the warning label was part of the randomized control trial, it outperformed the other label options with regards to the ability of participants to identify the product correctly as high in nutrient of concern or as unhealthy. When we compare the 2 other labels with each other, you can see that there were mixed findings. However, how did we get to that warning label that I have just shown you? We developed several prototypes with design companies and with our advisory committee, looking specifically at warning as this particular type of label that we wanted to pursue. And then we took those prototypes to qualitative focus group discussions. And the feedback from the focus group discussions were that a warning label would inform them about the unhealthy consequences of particular nutrients in food, and they perceived each of these warning labels as potentially beneficial. In a
Prof, you've just got 3 minutes left.
As a selection process, they then identified the triangle with the warning label on the left-hand side as their preferred label, and eventually that was then tested in further discussion groups. And maybe just to share with you some of the benefits that the population reported is that they said it shifts their focus from seeing the nice product with nice pictures on the front of the product to making them aware of the health hazards. And they were particularly sensitive to households who might have chronic diseases within the household, and that these warning labels will be beneficial for them. And in the end, the conclusion was that these warning labels will be easily understood by the less literate young people as well as the elderly, and that the various icons or signs being used on the labels can make it very clear for people that this is about access and that these products should be consumed with caution and not excessively. So finally, this is the warning labels that have been taken up in our labeling regulation, and we're hoping that the Department of Health would soon be able to publish the final regulation, which will then become part of our daily lives and mandatory to appear on food labels, and hopefully reduce the unhealthy food choices and work towards improvement of health in South Africa. Thank you very much.
Thank you so much, Prof. Sock, for sharing that presentation, which I think has very interesting applied implications for all of South Africans in terms of being aware of what we're eating and what we're actually taking into our bodies. So thank you so much. Our last presenter today is Ms. Govender. May I get that bio slide, please?
Hi there. Sorry, can I start sharing my
no, Mel's going to share your bio first and we'll read that and then you can present. Okay. Ms. Govender is currently a PhD candidate in the Department of Medical Bioscience at the University of the Western Cape. Chiara holds both a honours and master's degree from the Department of Medical Bioscience as well as the undergraduate degree from the University of Pretoria, where she graduated with a BSc in Human Physiology, Genetics and Psychology. Chiara is passionate about helping vulnerable people through science and has dedicated her current research to a clinical study that focuses on fetal exposure to maternal iron deficiency anemia and its effects on early childhood development. Over to you.
Okay, let me just share my screen quick. Okay, good morning, everyone. My name is Chiara Govender, and today I'll be presenting my master's research titled Investigating the relationship between depression and iron status of a South African university student population. Okay, so university marks an important trajectory in an adult's life as they transition from parental or guardian care to self-sufficiency, and is often associated with issues concerning well-being and behaviors. One such issue is the development of depression, a condition that is associated with increased feelings of sadness, guilt, and anxiety. Depression is often described as being biochemically induced or emotionally established. However, nutrition can stimulate the onset as well as the severity and duration of the condition. Specific nutrients are necessary to produce neurotransmitters such as serotonin, dopamine, and norepinephrine, which are necessary for the regulation of mood, appetite, and cognition. Iron is essential for regular neuronal and glial metabolism, neurotransmitter production, and myelination. As a result, iron deficiency has a negative effect on these brain processes, potentially leading to abnormal behaviors. As such, depression can potentially be associated with iron status in university students, and our aim was to assess this. Globally, both iron deficiency and depression are incredibly prevalent. Iron deficiency is the most common micronutrient deficiency in the world and was one of the foremost contributors to the global burden of disease. It is most prevalent in children, premenopausal women, and individuals living in both low-income and middle-income countries. With regards to depression, there are approximately 280 million people with the condition globally, with 50% of it being more common in women than in men. But in a South African context, a report published by the South African National Health and Nutrition Examination Survey reported that iron deficiency was prevalent in 15.3% of women of reproductive age. Furthermore, a study conducted by Patlani and team aimed to assess the iron status in a healthy South African adult population and found that 39.8% of the total population was considered iron deficient. Regarding depression, according to a report published by the World Health Organization in 2017, the estimated prevalence of depressive disorders was approximately 2,402,230 total cases, which is about 4.6% of our population. So before I get into some of the methodology used in the study, I thought it is important just to quickly run through how iron is transported and stored in our body. So we take in a daily amount of between 10 and 20 micrograms of iron. And of this amount, only 1 to 2 milligrams of iron is absorbed and bound to transferrin. Approximately 75% of body lipids found in circulating red blood cells, as you can see here. A further 10 to 20% of it is predominantly stored in ferritin and hemosiderin in your liver, spleen, marrow, and various other anatomical areas. And the remaining 5 to 10% of the iron is bound to myoglobin in muscle tissue and various enzymes involved in the oxidation metabolism and other cell functions. It is important to note that there is no available physiological process for the excretion of excess iron from the body other than blood loss, pregnancy, menstruation, or the exfoliation of dead skin cells or mucosal cells. Okay, to get into the methodology used in the study, it was a cross-sectional comparative study. Ethical approval was granted from the UWC Senate Research Committee, as well as the Biomedical Research Ethics Committee. Students were recruited via a mass email sent out using the UWC communication system. For the study, the main inclusion criteria was that the participant had to be a registered UWC student over the age of 18 and could not have any chronic medical conditions. So we had an initial inclusion of 71 participants, as you can see up here. Of the 71 participants, we had 8 that were lost to follow-up and a further 12 that were excluded due to technical difficulties experienced by our labs. Therefore, we had a total of 51 participants that were included in the study. Okay, so some of the information that we captured for our participants was their basic demographic information, sleep quality, as well as depressive symptoms. So with our sleep quality questionnaire, it was derived from a questionnaire called the Sleep Condition Indicator, which is a test used to screen for insomnia disorder based on the DSM-5. And for our depressive symptoms, we used the Montgomery-Åsberg Depression Rating Scale, which is a test used to measure depressive severity. For our anthropometric information, we captured the students' weight, height, hip circumference, and waist circumference, and used those measurements to calculate their body mass index, as well as their waist to hip ratios. For the iron status measurements, we had 5 total iron status markers, namely your serum iron, transferrin, total iron binding capacity, transferrin saturation, as well as serum ferritin. Iron deficiency was defined as having a ferritin value of less than 30 micrograms per liter, as well as a transferrin saturation of less than 20%. And depression was defined as having a MADRS score of greater than 30. Okay, so now we're going to step into the results of the study. As I mentioned, there were 51 participants included in the study. They had a median age of 20 with an interquartile range of 4 years. They were predominantly female students, making up 78.43% of the population, of Black ethnicity, making up 50.98% of the population, and in their first year of study, making up 41.2% of our total sample population. So table 2 presents the mean values of the iron status indicators, obesity measures, and depressive symptoms between our depressed and control groups. As you can see, we have this is in the way, we had 24 depressed participants and 27 control group participants. We used a Mann-Whitney-U test to discover if there were any significant differences between these variables and the depressive and control groups. Unfortunately, there were no significant differences in these variables, notwithstanding our actual depressive scores, which you can see here. So these p-values are all representative of the Mann-Whitney-U tests. And this table just represents our information in a more categorical form. It shows that 54.17% and 33.33% of the depressed and control group were iron deficient, respectively. After a Mann-Whitney-U test was conducted, I used the Spearman's rank order correlation analyses, and it established that there was no relationship between depression and iron deficiency, as there was no significance observed between the MADRS scores and the 5 iron markers, the BMI, or the waist to hip ratio values of the participants. However, Table 4 demonstrates the significant differences regarding the sleep quality questionnaire between the depressed and control groups. I used the Kruskal-Wallis H test, and it showed significant differences regarding the sleep quality. Here we can see it was less than 0.001 p-value, as well as feeling drained after waking between the depressed and control groups. Upon further investigation using a Kendall-Tau-B correlation analysis, statistically significant positive correlations were observed between the MADRS scores and the number of nights the participants had problems sleeping, their sleep quality, feeling drained after waking, as well as poor sleep affecting their productivity or concentration. Okay, so I'm going to discuss our main results a little bit more. In this study, as I mentioned, there was no relationship between depressive symptoms and iron status. However, various studies also observed that there was no relationship between these two conditions. Shariat Panahi, Su, and Okan and their respective teams reported no association between ferritin concentration and depressive symptoms in their respective sample populations. However, that being said, there were actually several studies that found a relationship between depression and iron deficiency anemia. So iron deficiency anemia is the most severe consequence of iron deficiency. It occurs when an imbalance among iron consumption, when there's an imbalance among iron consumption, iron stores, and the body's iron loss. Consequently,
5 minutes left.
Consequently, this can ensure an inadequate production of healthy red blood cells that just do not meet the body's physiological needs. Nurazar, Balsa, and Shafi had, and their respective teams had observed negative correlations between hemoglobin levels and depressive symptoms in their sample populations. So based on the results of the studies that assessed the relationship between depression and iron deficiency and depression and iron deficiency anemia, it can be assumed that perhaps depressive symptoms emerge in instances of severe iron deficiency, more specifically in iron deficiency anemia, a marker that this study did not assess for. Regarding the positive correlations observed between the depressive symptoms and sleep quality in the study, poor sleep quality can substantially affect the psychobiological well-being of students as they transition from high school to tertiary education. Many longitudinal studies have shown that insomnia often precedes the manifestation of depression and is also an independent risk factor for subsequent depression. When assessing the physiological observations in depression, Nutt and team reported that depressed patients presented with impaired sleep continuity, increased wakefulness, and reduced sleep efficacy. Furthermore, Lemma and team reported that stress levels, anxiety, and depressive symptoms were significantly associated with sleep quality in Ethiopian university students. The results of this study show that our university student sample population are at risk of experiencing sleep disturbance and poor sleep quality, potentially influencing their overall well-being. And lastly, just to speak about the limitations and strengths experienced in the study. For the first limitation, we did not record any food intake information, which would have been vital information, as iron is a micronutrient deficiency that is heavily influenced by diet. The second limitation was that we had a small sample size, and the third one was the period during which the data was collected or related. So data collection occurred during the COVID-19 pandemic, adjusted alert level 1. Students that were unvaccinated against the virus were fearful to attend campus and could not attend if they weren't vaccinated. Additionally, several students were just unable to attend physical appointments due to transport issues, or just were not in the province at the time of collection. This would have prevented students who were battling anxiety and depression from joining the study, ultimately affecting our sample size and underrepresenting those with the disorder. Regarding the strength of the study, at the time of this data collection period, and to our knowledge, it was the first study to investigate the relationship between depressive symptoms and iron status in a South African university student population. The study provides the basis for future studies to assess depression and iron deficiency within a larger South African university student population, either by assessing depressive symptoms and sleep quality using standardized sleep quality testing, or even assessing the relationship between depressive symptoms and iron deficiency anemia in a student population. These future studies will ensure that the next generation of young South African adults are healthy and equipped to take on their next chapter. Thank you. And these are my references.
Thank you so much, Ms. Governor, for sharing again some really interesting insights into depression amongst our university population group. I think it's interesting to consider things like iron, which can be added into your diet, but like you said, it's a micronutrient, so not always as easy to actually include into your diet as you might hope. That leads us to the end of our presentations for this first session. So I'm going to ask the 5 presenters from the second half to please put your cameras on as we will enter a time of Q&A, and ask the participants, our attendees, to please add any questions you have into the chat, or if you'd like to ask a question live, you are welcome to do that. I'm just going to check the Q&A box. We have someone congratulating Dr. Ahmed on their presentation. And I think the other comment was one for the previous group of presenters, the propensity score matching for that presenter. Any questions or comments from our attendees for our panelists? Or from our panelists to each other? We had some similar topics around depression and university students, so there's 2 presentations on that.
Maybe may I ask a question?
Yes, go for it.
And that would be to Ms. Govender. I mean, since we are both nutrition-related kind of presentations, so I don't know whether you saw the presentation. There won't be a nutrient warning on iron, because iron is a positive nutrient and hopefully to be recommended. But are there other nutrients that you think could impact negatively on the absorption or the consumption of iron, which you are worried about and which you think we should be watching on?
That is a great question. I have been reading articles on vitamin B1 and I think vitamin A that are all related. But of course, especially in students, that's why the aim was a university student population. You know, there's just so much stress going on, and who's even eating properly. I think those are the ones that I have read. I obviously have to read a little bit more just to see how any are related. But yeah, those were the 2 that I read about.
There's a question that comes through and says, do we have insights on estimated travel times to healthcare facilities in South Africa? why 15 and 30-minute travel times are these international norms? And that goes to, oh, that was?
It was me
yes.
that did the
That-
presentation on the travel
yes.
times. International norms, we don't have really a set time frame. Usually it is within 90 minutes or 5 kilometers. That is the recommended distance between the recommended distance from how far you should be from a healthcare facility. But other than that, there is no like basic set time for it. The reason why it was chosen in 15 minutes or 30 minute intervals was because this was the data that was collected by Statistics South Africa in the General Household Survey. So we went according to those categories. And then for the logistic regression, did it in less than 30 minutes and more than 30 minutes, just to give a basic estimation of do they travel in shorter times or longer periods according to the 5 kilometer distance recommendation from the World Health Organization. If that makes sense.
Okay, thank you. Mr. Farah, would you like to ask a question live? You may speak. Brendan, you're unmuted, but we can't hear you. Oh, you're saying that the question was answered. Great. Perfect. Any other questions for our panelists? Any other comments from our panelists to each other? Nothing at this stage. And then thank you so much to our presenters, both these last 5 presenters and our previous 5 presenters as well. Thank you so much for sharing your valuable research of what you've been working on. It's always so exciting and encouraging to hear what research is being done within UWC, and both really practical stuff that has bearing on our everyday lives, really. So I'm very excited to hear what happens from all of this research going forward. And thank you all so much to our attendees for being here today. We would like to encourage you to join our next session, which starts at 1 o'clock. So we have an hour lunch break, or just over an hour lunch break. And thank you so much for being part of our research week. And we look forward to seeing you in the next session. Thank you so much, everyone.